organs with the recipients and expanding the pool in a safe and effective way. So Norah, thank you.
So I'm actually gonna, full disclosure here, focus on the hepatitis C. I'm happy to talk about HIV in sort of the question period, but I wanted to focus on hepatitis C just in view of the time and the fact that it's a much more kind of common scenario at the moment. And the question is really, why has it become such a big thing in the recent months, last year? Really two things contribute. One is that we have much fewer HCV patients on the waiting list. This is data from the European Liver Transplant Registry, but the US data looks very comparable, and you can see that in the DAA era, since we've had effective HCV therapy, that the number of HCV patients on the wait list and the ones that are undergoing transplant has dropped by at least 50%. And in fact, in many programs now, we're seeing that most of the patients coming to transplant are more likely to be HCC patients. And even of those that are coming to transplant, many of them have already been treated, and that therefore HCV uninfected, even though they previously had HCV infection. So in the past, where we used to take all our HCV positive organs and just put them into HCV positive recipients, that's no longer easy to do because we have less patients on the wait list who are available to do that. And the other significant event, at least in the United States, and this may not be global, is that we have a significant increase in the number of HCV viremic donors. And that's in large part related to the opioid epidemic, and shown in the New York Times. It's sort of it's the silver lining really in this horrible problem that we have in the United States, in which we're seeing more than 50,000 deaths annually from drug overdoses. Most of those individuals are under 40 years of age. And among that population, HCV infection is quite common. We're seeing 30,000 new HCV infections annually, so it's our new epidemic of HCV as well. And of those that use drugs, somewhere around 15 to 30% of them will get infected in the first year of their use. So we have a coming together of two things: fewer people on our wait list who are sort of available to take HCV positive organs, meaning the patients who have HCV infection already, and a much greater number of organs that are available to us. And so that's really sort of brought the transplant community to the point where they're saying, where can we put the HCV positives into HCV negatives? And that's also attractive for another reason, and that is that the donors are also of high quality. As I mentioned, most of these are young donors under the age of 40, and shown on the left is really the mean deceased donor age by HCV status. And you can see that really the HCV patients that we now are sort of offering as donors are often very young, and because, aside from their drug use, really often have very few other comorbidities. And so that makes them very attractive donors for kidneys, for livers, and other organs. And in fact, we already have seen since about 2012 that those organs are being used much more. They are younger donors, they are otherwise high quality donors, and so as a consequence, they are being used more in the United States and in other countries where they're available. And then the other sort of factor that comes into play is we've got some data, and the data is not in livers, but in kidneys. And you're all very aware of the Thinker and the Expander trials. These are a very modest number of patients, a total of 30 across the two studies. But it's a real proof of principle that you can take a HCV positive donor, give that organ to an HCV negative recipient, use HCV therapy in the early post-transplant period to treat the patient and have good outcomes. And so in this study, they took only genotype 1 donors because they were using the drug combination elbasvir-graçapavir, which is only effective in genotype 1 and 4. And it's a drug they chose because it's safe to use in patients who have all levels of renal dysfunction. That's not true of every DAA combination we have. And they started treatment typically within days of the transplant. So shown on the figure on the left are the levels of virus, and you can see essentially all patients were positive for virus within a few days of their transplant and had viral levels that are often 6 log or higher. But you can see with treatment, which was initiated on average at around day 3, then with over the 12 weeks of treatment, the viral load became undetectable. And in this study, 100% of the patients were cured. So of the 30 patients that have been transplanted with kidneys, we have 100% success in terms of our ability to cure those patients post-transplant. So it's not surprising that now this is moving into many other organs. And surprisingly, liver transplant is a little bit farther behind. There's actually no or very little published data and very modest number that have been presented. There is one multi-center study that's underway called PROACT, which will yield data, but not for some time. And I would say that livers and kidneys are different, and they're different for a couple of reasons. One is you're taking an organ that has HCV infection, and the quality of that organ is going to be important to the recipient. And while I talked about the young donors, there may be other donors that are going to have some degree of liver injury from their chronic hepatitis C. The DAA options that we have are influenced by the function of the liver and by the function of the kidneys, and we often know that many of our very high MEL patients have both severe liver dysfunction and kidney dysfunction that doesn't always immediately get better after transplant, so that's going to influence how we treat. And then secondly, there's an issue of the DAAs actually being associated with immunological graft dysfunction. So we have to think about that since the organ, the liver, is really full of virus and the immune cells that were associated with that infection in the donor. So what data do we have? This is just one case report. This actually comes from our institution. It was the first patient we did. And it's part of a theme, and that was in that we had a patient who had HCC, was treated, but at UCSF, our wait times are very long. And so while on the wait list, he got treated for his hep C, and he was cured. And then he was on the wait list, and his cancer started to become very sort of difficult to manage, and we were concerned about wait times, and so we made that patient available to an HCV positive organ. He got transplanted with an HCV positive donor, and you can see that his genotype changed from being genotype 1 before his transplant to acquiring a genotype 3 infection. And then we retreated him after transplant with a different drug combination, and he was successfully cured. Now this is actually a pretty easy sell because you take a patient who's had hep C, they've been treated, they get it. They get what hep C is about, they get what the DAAs can do. It's a lot easier to go through an informed consent with such a patient than somebody who's HCV naive, who really doesn't know anything about hepatitis C, doesn't know what it's like to be chronically infected or to be treated. So the only other experience that I'm aware of is data that was presented at the recent ACT meeting. These are 11 patients from Stanford that were also transplanted with a NAT-positive donor. Again, the theme continues. 7 of their 11 patients were actually patients who had had hep C before, treated and cured, and then were offered a donor that was HCV NAT positive. So shown in the figure on the left is at the time of transplant, you'll see that very quickly the patients become viremic. So within days, most of them have infection that's several log high. And then they started their DAAs on average 38 days after transplant. So very different from the kidney experience where they're starting the treatment at day 3. This is really almost a month after transplant, and in some cases 2 months post-transplant. They didn't report their cure rates because they didn't have data out that far, but all the patients on treatment had an undetectable viral load, and they followed them 4 weeks after treatment, and so far there's been no relapses or treatment failures. But the interesting thing in this study is that 4 out of the 11 patients had rejection, either acute or cellular rejection or antibody-mediated rejection, a rate that's higher than you would expect to see in a patient population such as this. So it raises the question of whether there's some immunological dysfunction that may be occurring in the setting of this new HCV infection that does make your recipient at higher risk for rejection or other immunological challenges. So now what I'm going to do is really try to walk you through, if you're going to do this, what should you think about? Because I think it's going to be done. I think many centers are doing it, and I think we want to know how to do it in a safe way. And so what I'm going to try to do is really kind of walk you through how I think we should think about it. So just to summarize that we've got very little data in liver transplant patients so far, but I think that's encouraging what we see. And what I'm going to try to do is sort of hit on 4 key issues. And the first is really this issue of donor quality and the fact that it really matters a lot more in a liver recipient because you're going to give them a liver as to what the sort of status of the chronic infection was in the donor. Backwards. So I think there's largely 2 buckets that patients fall into. One are these, in the US, these injection drug users who are young, usually have acquired their infection relatively recently, and those individuals, I'm sure, will be very unlikely to have significant fibrosis. They could, but it would be unlikely. But we also have another organ pool, and in Europe and in other countries, this may actually be the larger HCV positive donor pool, and that is the older patients who've had their hep C for decades and now may have been treated and cured, and now they die and become a donor, or they're still infected because they haven't been identified yet. Those individuals are much more likely to have advanced fibrosis on their liver, and they're more likely to have things like associated steatosis, perhaps other comorbidities. So they're a different donor, and I'd say donor quality probably less or more variable in that group compared to that young donor group. So what we know is that that's important, and it's important because from our work in chronic HCV, we know that age of the donor and the level of fibrosis does influence survival. So these are chronic HCV patients who received HCV positive donors, so not exactly the scenario I'm speaking about, but it already makes the point in this study that if you have any fibrosis at the time you're transplanted and you have HCV, that disease seems to be more rapidly progressive than patients who don't have any fibrosis. And the other thing is that an older donor, if it has fibrosis, is going to be a more rapidly progressive disease than a younger donor. And that's been shown in many of our studies. These are 3 just representative ones in which older donors and those with baseline fibrosis were more likely to have a reduced survival. So if we take this data in chronic, C into C, and now do a HCV into an HCV negative, I think we still have to be concerned about what the donor brings to the recipient in terms of the stage of liver disease. So the AST put out a statement about how we should think about donor selection in using HCV viremic donors, and they recommended that you should always do a liver biopsy and that the biopsy should show F1 or less. So anybody with significant fibrosis should not be used as a donor in this setting. And the rationale for this recommendation is that, first of all, staging is not perfect, and there can be understaging, even if you are looking at the pathology specimen. This idea that if you have fibrosis at baseline and then you have HCV infection in the setting of early immunosuppression, that could be a more rapidly progressive disease. And then there was also the concern of sort of second hits. You take an organ that, let's say, has more advanced fibrosis, you give it to a recipient, and even if you cure them, that fibrosis isn't going to reverse necessarily. And then if they get a second hit from CMV hepatitis or they have a biliary complication, then that's a graft that's really at significant risk in terms of loss. So because of that, we want to really select an organ that is going to be very likely to tolerate what other insults may be forthcoming in terms of being a transplant recipient, hence the recommendation for the F1 or less. So the issue too is the timing. So we saw the kidney experience very different from the initial liver reports in terms of when they started treatment. And I'm really a proponent of preemptive therapy, which is what they're doing in kidneys, and that's when you start the treatment either at or very soon after the time of transplant. In this case, it would be liver transplant. And I think the advantage here is you're really trying to prevent disease. You really want to not allow that individual to get a hepatitis. Now, the tricky part, of course, is that it's difficult actually to use these drugs very early after transplant. One is, many patients are NPO for 24, 48 hours. Sometimes their renal function is not good. Sometimes their liver function is not good. And those things make it hard for you to choose your drug combination to treat the hep C with, because we have some drugs that are good for patients with renal disease, and they're different from the ones that are good for patients with liver dysfunction. So it could be tricky. But that being said, if you have somebody who's a pretty stable course, I think preemptive therapy really is the right strategy. As has been done in the reports so far, many have done the delayed approach, which is where you wait for viremia to occur, you kind of document the infection, you wait for the patient to be otherwise stable, and then you initiate treatment. And the advantages there is that you, A, document that they're viremic, and you allow yourself to not have to deal with fluctuating renal and liver function. But I think the disadvantage here, especially if you wait 4 weeks or 8 weeks to start treatment, is that you may then start to see the manifestations of severe HCV disease, because we know that a newly infected patient with maximal immunosuppression is really at high risk for getting a very severe form of hepatitis. And probably the one we worry the most about is cholestatic hepatitis, which is this hyperbilirubinemia, jaundice, and association with a sort of rapidly progressive disease. And I show you this table really not, this is again, not in patients that are doing a positive into a negative, but this is just patients with chronic hepatitis C. But just to highlight 2 things. One is that the onset of cholestatic hepatitis can be soon, within a month of transplant, as highlighted in the table. It also can be as long as a year later. But the other thing is that they rapidly progress. So if you look at the first patient, for example, who at the onset of their cholestatic hepatitis, which was 3 months after transplant, by the time they were treated successfully for their hep C, even though they were successfully treated, they then had F4 fibrosis. So even though you're successful with getting your drugs on board, the patient can still incur a fair amount of liver injury and be stuck with a significant amount of fibrosis. And sort of probably the sort of big elephant in the room for all of us is just the access to the drugs, and knowing that we can get access to them and that the patient will get access to them not only for the first course, but if they fail the second course or the third course. DAAs are expensive, that's well known, and the access to drugs varies a lot by country. and even region. So in the States, it varies by state as to how you get access to your drugs and how easy it is. None of them are approved as preemptive therapy post-transplant, so you'd be going off-label. And the authorization process, even in excellent hands, like in my clinic, can take weeks in some cases. And so think about that. You're gonna have a patient who's got infection and you're trying to work through an authorization process to get their DAAs. So I think the implications for transplant programs who are going to do this, taking a positive and putting it into a negative individual, is that you have to guarantee that that patient has access to drug, and that means you have to be responsible for that. So I think the transplant programs have to have a plan in place for how am I going to ensure that the patient has access to DAs in a timely fashion. That may mean that you have to pay for them. So that has to be, I think, upfront determined. I think as a community, what we need to do is all of us need to advocate to remove all barriers in terms of access to DAs. It's ridiculous that we still have them, but they are there. And I think as a transplant community, we should be pressing to ensure that any patient who gets a transplant and needs DAs can get them and get them very, very quickly. So the third issue is, what are the DA-associated complications? We all think that they're very safe and they're great drugs and they're very well tolerated, and all of that is true. Less than 1% of patients actually stop DAAs because of an adverse event. So that just speaks to their safety very, very broadly. But there are tricky, we have 6 different drug combos that are approved, but some we use in patients with renal dysfunction, and the difference that we use for patients that have liver dysfunction. We can't use protease inhibitor inclusive therapies if patients have hyperbilirubinemia. We can't use sofosbuvir if the patients have a creatinine clearance that's under 30. So there are some tricks to it, and sometimes I actually have patients where I actually have no approved therapy that I can use on them. Even though I need to treat them, I'm going to have to go off label. I'm going to have to take on risk of using a drug that's not been studied in that particular setting. So while we have good options and they are generally safe, when you have a complicated patient, you may find yourself in a situation where you don't have a drug therapy that's approved for that use. And again, that whole access to drugs can then become even more complicated. The other thing is there are some drug-drug interactions. They're not major, but they're there. So for example, sofosbuvir is contraindicated in the setting of amiodarone. So if your patient goes into an arrhythmia, you have to be very thoughtful about that. You have to be aware antacids influence the success of these therapies. You can't use high-dose PPI therapy if you're going to use sofosbuvir therapy, and the list goes on. So there are drug-drug interactions that occur, and those can be more complicated to manage in the immediate post-transplant period in some of our transplant recipients. Immunosuppression is not such a big issue. Cyclosporin does interact with some of the protease inhibitors, but in general, very few drug interactions in terms of immunosuppression and the HCV DAAs, which is a plus. And then recently, there's been a publication about immune dysfunction in patients who were treated with DAAs, reminding us that they're not benign. And this was a recent study, 6 liver transplant centers. They identified 33 cases of immune graft dysfunction in the context of DAA therapy. And in these 6 centers, that was out of 978 patients treated, so 3.4%, so not high. They were all manifest by liver test abnormalities, and they got biopsied. And the biopsies showed, as you can see in the bar graph, almost half the cases were plasma cell hepatitis, but they saw acute rejection, chronic rejection, and some combined elements. And in most of the cases, these were treated by amplification of immunosuppression, but they did have one graft loss in the setting of DAA therapy. So just to remind you that they're very safe, and in general, we don't think about them as being immune modulatory, but clearance of the virus can probably have some immune effects. And the other thing that happens during treatment, this is a patient of ours that was treated successfully with sofosbuvir and ledipasvir, is that interestingly, as they're clearing virus, we note that your immunosuppression levels tend to drop, whether it's due to improved metabolism of the drug, what the underlying mechanism is unclear. But as you can see in this patient who we were treating, at the beginning of the treatment, they were on 4 BID of tacrolimus, and by the end of the treatment, to maintain a same level of tacrolimus measured in the serum, we had to increase the level of dosing up to 5 milligrams BID. So just, you have to do the monitoring. If you're not going to monitor, you're going to see the levels fall, and that, of course, places the person at risk for rejection. So it's not easy. So all of this, I think, comes down to the informed consent, because this is something we want to do, so we have to do it, and we have to fully inform the patients of what their risks are. And while most of the things that I've talked about are extremely rare or uncommon, it's not zero. So we need to tell our patients about the worst case scenario. What is that? Well, you could get this DAA-associated graft dysfunction. You could end up with chronic rejection. You could have an untreatable HCV infection. While the DAAs are successful in 95% of patients, there's 5% who fail. And then of those that are retreated, 5% of those will fail. So I have patients where I've treated them with 3, 4, 5 times with DAA combinations and have not cured them yet. So it's rare, but it can occur, and we have to tell our patients that. And then I already commented on this issue of risk. So I think it's actually quite hard to talk to patients who've never thought about Hep C, about what it means to get infection, the fact that you're going to give them infection and then you're going to plan to cure them. And I think a lot of them are still worried about the stigmatization of having had Hep C. I think they're less worried about the fact that I won't cure them, but more that I will have had Hep C and what that would mean for them in terms of insurance and other things, or what their family might think, what they might tell their loved ones, et cetera. And then the other thing is that most of these donors are high-risk donors. So not only you have to tell them, I'm going to give you a NAT-positive HCV donor, but that donor is also at risk for HIV, for HBV, because that comes with this donor risk group. And so patients often have some concerns about that as well. So that all may seem a little bit negative, but I really am here to say I think we should just be doing it very, very thoughtfully. And then my final point is going to be that we should do it because it's really the right way to save lives and to save dollars. And this is a very recent publication that came out. It's a modeling study that looks at the change in life years if a recipient on the list agrees to take any donor, as opposed to waiting for an HCV negative donor. And what it looks at the life years gained in doing that. And in this model, we assume that all the patients would be treated with preemptive DAA therapy with a success rate of 90%. And what it really shows is that there's really, the right thing to do is to accept an HCV positive donor. It's cost effective in anybody who's got a MEL score of 22 or higher. And in the orange bar is shown the median MEL score in the United States. And if you chose that median MEL score and accepted the liver, the incremental cost effectiveness ratio for that is about 62,000. So it's cost effective, and you are going to definitely be saving lives. The number of lives you'll save will be dependent somewhat on how many HCV positive organs you get access to. So this is one last slide just to show that in the United States, there are some parts of the United States where they see up to 12% of their donors are HCV positive. So that's a remarkable amount. That's in region 1. And so obviously in those regions where they have access to these donors, the ability to use them and use them well in their recipients is going to really result in a significant benefit in terms of those life years gained and in cost. So my summary about HCV positive is really to say these are excellent donors, but we should think about the age of the donor and think about a clear assessment of fibrosis in thinking about accepting them. The natural history of Hep C in this scenario is actually not known. We really don't know. If you take somebody who's negative, give them positive organ and left them untreated, we don't know what that's going to look like, and we don't want to know. But I do think that we know that already HCV is, that natural history is going to be accelerated. We do not want to see cholestatic hepatitis. So I really feel like a preemptive or early treatment approach is essential. Post-transplant infection is curable in the vast majority of patients with one course of treatment, but you are going to see failures, so the patients need to know about that. And again, that access to drugs, whether it's 1 course, 2 courses, or 3 courses, has to be guaranteed in my mind. And then finally to say this is the right way to go, though. Accepting an HCV positive donor is cost effective, and we're going to save more transplant lives by doing so. And that's it. Thank you.